hour lecture compressed into 10 minutes. So hopefully I'll try to do this very quickly. No relevant financial disclosure. So there's two different types of dysphotopsias, positive and negative. I'm going to focus on the negative dysphotopsia. And the negative dysphotopsia is where you get that dark shadow in the periphery, in your temporal periphery. Usually it's after a completely normal, uncomplicated surgery, and the main issue is, why is it there? How do we get rid of it? How do we prevent it? It was first noted by Jim Davidson back in 2000, and unfortunately since then we still don't really have the absolute complete answer, but we do have some clues, so I'll share what we found. All right, so what we did was we started seeing this, and so we said, well, let's learn about it. So we did a peer-reviewed literature search, and we looked at everything, and this is what we found. We found 58 reports, and most of them, as you can see, were really consultations. It was just people thinking about what could this be. It was not many prospective reports at all. So we published this in 2015. Since then, let me just go through what the etiologies are, and then at the end, I want to give you a hypothesis of how we can prevent it. So here's the etiology very, very quickly. So the idea is that you have to have a normal retina, and you have to have a normal anterior functional nasal retina. So you have to have enough nasal retina so that the shadow can be on that retina, so that you see the shadow on your temporal periphery. It's most often related with lenses that have a sharp truncated edge, and oftentimes it's the high refractive index acrylic lenses. And a lot of this work was done by Jack Holliday, and he's really published the majority of the literature on the subject. And he surmised that it's because when you have a sharp edge of the optic, the light rays hit the sharp edge and it crosses, so there's an area of the retina that's not illuminated. If you look at the rounded edge, actually the rays cross in that area, so you don't have an area of your retina that's not illuminated, hence no dark shadow. So he also looked at a whole bunch of other factors. Why is it more in acrylic versus silicone? And I know this graph is really small, but in the graph on your left, that's the acrylic lens. And it looks like if you take a look at the space between the back of the iris and the front of the IOL, that space, when you reflect the light in that area, you get a larger shape, temporal crescent shadow with an acrylic lens because of the way the light is scattered versus silicone. So in the silicone, you do get a dark shadow, but it's very, very small, so it's not as obvious. So the problem is there's lots of controversy around each of these etiologies. So I just told you about a sharp edge acrylic lens, but there are plenty of reports that say, no, actually we see it in rounded edge lenses, we see it in silicone, we see it in PMMA, so we see it in all different types of lenses, and they even measured the distance between the iris and the IOL, and there seems to be no difference. Now, pupil size is one of the etiologies that they've really pinpointed, and we do know that if we actually make the pupil smaller, it makes it worse. So we know that if we dilate the pupil, it makes it better. But we can't really dilate everybody just because they have negative dysphotopsia. That's not a good cure. So, and we can't really change pupil sizes without constantly pharmacologically giving them some drops. And who wants to be an eye drop to change their pupil size, right? But it is related with smaller pupils. Another etiology, this is Sam Maskett's etiology, is that somehow there's a relationship between the lens and the anterior capsule. Not quite sure what it is, but he thought that every single time he's seeing negative dysphotopsia, the lens is always in the bag. And he's saying that he never sees it in the sulcus, and it has to be some type of way the light is hitting the lens, hitting the back of the anterior capsule, and therefore reflecting on the retina. Unfortunately, that's not true, because I just saw a patient a few months ago that actually had a lens in the sulcus and had negative dysphotopsia. So that can't be the only etiology. So there was another theory, well, maybe it has to do with the patient's anatomy. So maybe it has to do with how their eyeball is shaped or their orbit is shaped. So when you actually look at the bilaterality of negative dysphotopsia, it is really likely that if they have it in one eye, they're going to have it in the other eye. So in Jim Davidson's report, 100% of his patients, if they had it in one eye, they have it in the second eye. In other reports, it's up to nearly 50%. So most likely, if you have it in one, it's in the other. So again, it probably has something to do with that patient's anatomy alone. Bobby Osher did a lot of work. He thought maybe besides the eye itself, it has to do with the orbit. Maybe a shallow orbit predisposes to it and a prominent globe. There's also some neuroadaptation retina theories, and I won't spend a lot of time. There's two retinal theories, and basically the idea is that maybe the retina isn't allowing the rods to stop stimulating. So in the cones, they stop stimulating, and so you don't have that shadow, but in the periphery, you have more rods and cones, and they tend to overstimulate. That's one theory. Another theory is that there's a zone of dark next to light illumination, next to the shadow, and so you have some overstimulation and some inhibition. Again, I'm not going to go into details because of time, but those are the two retinal theories. There was another theory that Bobby Osher put together that he said, well, maybe it's because we're doing clear corneal incisions and there's some temporary edema around the clear corneal incision, and that's why we see the dark shadow resolve after about a week or two, and maybe it has to do with the clear corneal incision. Sounds reasonable, but then since then there have been other reports that say, no, we see it in superior incisions too, so it can't be just that. So as you just heard, there's lots of different etiologies for why, but now what do we do to treat it? So there's non-invasive and invasive approaches. The non-invasive approaches is just to wait and say, well, you know, it's gonna get better, don't worry. And oftentimes that works. It goes away after 6 months to a year. Maybe it has to do with the opacification of the posterior capsule, maybe. Maybe it just has to do with the adaptation of the brain getting used to it. Some people just recommend getting glasses with dark frames so it blocks out that light. Again, hard to say. Sometimes you just operate on the second eye and they just ignore the first eye. For the invasive approaches, people have tried yagging the anterior capsule, thinking that maybe the relationship between the anterior capsule that overlies the optic. So if we take the YAG laser and cut out part of the nasal anterior capsule, will that solve it? Well, some reports say yes, it does, and some reports say no. And I actually tried this on a handful of patients. It didn't work. So again, it's kind of up in the air. So people have said, well, it must be some relationship with where the lens is sitting. So let's move the lens. Let's pop it anteriorly to a reverse optic capture, and that seems to work in some patients, not in everybody. Maybe we could piggyback the lens and break that kind of ray of light. And again, sometimes that works, but not all the time. Maybe we can just move the lens by suturing to the iris. Again, sometimes that works, sometimes it doesn't. Or maybe we have to do a lens exchange. And again, sometimes that works, sometimes it doesn't. So as you can see, it's still kind of a mystery. So, and there are reports on both sides. So even if you do a lens exchange for a lens that has rounded edges, it's different material, it's a silicone lens, you're still gonna get negative dysphotopsia in some patients. So it's not a cure. So now that I just confused you completely, and I just told you that there's probably anatomical factors, someone has a functional anterior nasal retina, we want the lens in the capsular bag, that's where it's supposed to be. Sometimes they have a small pupil, we can't do anything about that, and sometimes they have a shallow orbit and a prominent globe. So if you have these variety of factors, and you're using a one-piece acrylic lens as your primary monofocal lens with a sharp edge, then this is my hypothesis. So we thought, well, if the light is hitting the edge of that acrylic lens and shining against the retina and there's a big gap, well, what if we actually try to shift the lens and so that the haptic optic junction where there is no edge, we can put it in the area where the light is coming through. The reason I came up with this idea is I had a patient who was an excellent historian. She had come to see me, I think, for a fifth opinion, and she said, you know, doctor, if I go like this, and I block the light just coming directly from there, it goes away. She said, literally, it's right here. And then she said, if I actually look down so that the lower lid blocks that area, it goes away. But it's there if I look up, it's there if I don't do that. So I thought, well, it must be the light coming from there doing something. So I thought, well, what if I just orient the lens, the one-piece acrylic lens, because with the one-piece acrylic, you have this shoulder area where there's an optic haptic junction. There's no edge. And that's about 1/3 of the whole circumference of the IOL. So if we just shift it in that area, in that infratemporal or horizontal area, and we just block 1/3 of the edge, maybe we're gonna decrease the incidence by 1/3. So I said, all right, let's study that. So we went ahead and did this is a proposed position, and we went ahead and did a prospective masked, multi-center contralateral eye study, where in one eye, they had the study position, which is in the infratemporal horizontal position, and in the other eye, they had a vertical position, and the patient was masked, did not know which eye was which, and so this is what we did, and we did 319 eyes. There was a whole nother 100-arm study where we did a silicone 3-piece lens to see the incidence of silicone versus these acrylic. And very quickly, what we found was, in fact, it worked. So if you actually position the eyes in the horizontal position. It decreased the incidence of the early incidence only though. This unfortunately did not hold when it was longer after a month. So unfortunately, it's not a long-term fix. It doesn't solve the problem. It's not 100%. But if you want to decrease the incidence of early dysphotopsia just by orienting your one-piece acrylic in a horizontal position, I think it's an easy thing to do. There's no risk, there's no downside. Why not? So this is my proposal. So go ahead and just position the optic-haptic junction more horizontally, and I think that will decrease the risk. So in this trial, we actually, the evidence was so strong that we ended up stopping the trial early and only putting the lens in the study position and continued to follow. And in fact, what we found was there was a very, very significant decrease in the incidence of negative dysphotopsia in the first week. As an update, Jack Holliday actually looked at this and he said, but Bonnie, it's not actually the infratemporal optic haptic junction, it's actually the supranasal haptic junction that's blocking the light. So it actually is not that side, it's actually up here, but it's the same position, it's the same horizontal position. So what he did was, this is a new publication from him from last year, and he has now added, as his primary factor for risk of ND, he's added, make sure that you place the optic haptic junction of the IOL and make sure that it's try to be horizontal or 30 degrees infratemporally. Right. So conclusions, multifactorial, we still don't know exactly what it is. I think it's a combination of factors because there's no one thing that we can point to, but if you're using a one-piece acrylic, go ahead and put it horizontally, and I think that will help. Thank you very much.